Good morning, ladies and gentlemen. It's probably afternoon in Malta, evening in Myanmar, and almost 8:30 in the evening in Australia. Welcome to the series of webinars which have been run by the Royal College of Surgeons of Edinburgh. Today, we're going to discuss the post-lockdown strategy for non-COVID essential and emergency surgery. The world has experienced an unprecedented pandemic since January 2020. Countries have responded according to the prevalence of the virus, their healthcare resources, and offered guidance to the public. The Royal College of Surgeons of Edinburgh have responded by providing guidance and advice through working with surgical societies and sister colleges, essentially providing guidelines to members and fellows and education through webinars. Many countries have now seen the worst over and are beginning to ease the restrictions. It is now timely to hear how our international partners are dealing with going back to work in the so-called new normal. We have assembled eminent surgeons from Australia, Myanmar, and Malta to share their experience and views on the strategy from their countries on the way forward. I would like to introduce Professor Jonathan Serpell from Melbourne. He is a professor of endocrine and breast surgery in Prince Alfred Hospital. Professor Joseph Gallia, who is a consultant cardiothoracic surgeon in Malta and is also the president of the Association of Surgeons of Malta. And Professor Zaw Paiso, who is the rector of the University in Yangon 1 in Myanmar. Gentlemen, we extend a very warm welcome to you all, and I would like to personally thank you on behalf of the College of Surgeons of Edinburgh for having taken the time to inform us of your strategy in your own countries. Thank you very much. May I now request Jonathan to share his views, please?
Yes, thank you very much, Raj. Just sharing the screen and getting going. Firstly, greetings from Melbourne. It's the morning in Edinburgh and it's the evening here in Melbourne. But I'd like to share with you some perspectives on COVID-19 in Australia. And thank you very much indeed for asking me to contribute to this webinar. This is the daily summary of statistics that the Australian government produces, and I'll come back to it, but essentially Australia's been fortunate in having a low case number, 7,290 cases, and only 102 deaths thus far. And I just wanted to highlight that in mid-March, there's been just one surge in case numbers. So that with that surge, the borders closed both external and internally between states and territories, and lockdown commenced and has continued from March really until the end of May. And in Victoria, for example, one was allowed to leave home only for essential work if you couldn't work from home, or essential supplies, medical appointments, and to exercise. And at the same time, elective surgery was cancelled, but there were exceptions to this, and these included Category 1 cases, which would normally be done within a month, such as cancers, or urgent Category 2 cases, which would normally be done within 3 months, likely to deteriorate in that time, and emergencies as well continued. And the rationale for this, as we know, was that it was important to preserve PPE, ensure availability of intensive care beds and ventilators, and ensure bed capacity for the expected surge, which we felt was about to happen. At our own hospital, the Alfred Hospital in Melbourne, the emergency department was envisaged it would expand across the whole of the ground floor, and in fact it took over the boardroom, and there are now 8 ED cubicles in our boardroom. The ICU capacity was envisaged to expand from 60 to 350 ventilated beds. It was envisaged there'd be multiple COVID-19 units and a plan to double the overall capacity of the hospital. And at the same time, geographic clusters of public and private hospitals were created, and the Alfred was a leader in our geographic group and deemed to be the hospital where the ventilated beds would be. Our college, the Royal Australasian College of Surgeons, and the 9 associated specialty societies produced guidelines as to which electives could or should be done. But essentially for most units, this meant that we went from perhaps 10 operating lists a week to a handful of cases only a week. But by late April, gratifyingly in Australia, there had been no surge of cases and the curve had dramatically flattened out. And we had the unusual situation at the Alfred Hospital of many empty beds and low activity. So at this point, our National Cabinet recommended a cautious, incremental approach to recommencing elective surgery. The principles were it had to be safe, it had to not increase any risk of intra-hospital transmission. The cases had to be high value and of low risk need for ICU, so that if needed, ICU and hospital capacity could expand. There had to be a minimal need for PPE, and it was envisaged that electives would increase by 25% of their previous very low level at that stage. There was to be equity of access, regardless of public or private status. Agreements were struck between public and private hospitals to provide surgery for public patients in private. And in this way, public waiting list patients were treated. And in fact, this morning I did 2 such patients of the Alfred at a private hospital. And this also helped, of course, private hospitals maintain their throughput and their financial viability. The impediment has been the shortage of PPE, in particular in Victoria. This has been a shortage of appropriate face masks. And there was a strict control over case numbers. Each hospital, public and private, had to report on a daily basis case numbers to the Department of Health. By mid-May, again, it was clear there wasn't any further surge in cases, and it was decided to further incrementally increase elective surgery so that it was at a 50% level by the end of May. By the end of June, it's envisaged it being 75% and 100% by the end of July. And in parallel with this, there has been a slight easing of lockdown restrictions. This has varied a little bit state to state. Waiting lists were reviewed and assessed for possible deterioration to create that important group of urgent category 2s. And all outpatient referrals were reviewed and triaged. Again, coming back to these statistics, Australia has been very fortunate with low overall case numbers, 102 deaths only. Just to highlight, the graph shows it's a disease of the 20-year-olds onwards. The deaths occur in the elderly, more in the males. And in Australia, the greatest density of cases is in the eastern seaboard, which are the 3 most populous states. These are some of my personal views, but I just wanted to highlight 2 things here: that there's been a high COVID testing rate of 7% of the population and 0.4% positive. And there have been some positive outcomes, I think. The utility of telehealth has clearly been established. Video conferencing such as this or Microsoft Teams is wonderful for audit, morbidity, mortality, business meetings. It's underlined the value of hand hygiene and hand washing to prevent infection. it's highlighted that it's unacceptable to go to work when you've got a cold or flu. And as we move into winter here in Australia, there's been a higher influenza vaccination rate and a much lower influenza infection rate than usual. So there's no doubt, and I want to underline this, that the pandemic has created havoc for the whole world. But Australia has been very fortunate. But there's a long way to go. There's a clear need for a vaccine. There's a risk of second and subsequent waves. And clearly it's been a massive social, health, economic and employment cost. Thank you.
Thank you very much, Jonathan, for your comprehensive review. I will now request Professor Zaw to give us his perspective on Myanmar, and then Professor Joseph Galea, and then we'll open the floor for questions. Would that be all right, gentlemen?
Yep, that's fine.
Thank you very much.
Professor Zaw.
Thank you, Raj. Can I start, Raj?
Yes, please.
Right. Okay. I think we have to greet like a good day, because nowadays is only we can say day, because morning, evening, afternoon very difficult to say. It has been very great honor for Myanmar and also for us to participate in the college webinar and to talk about the Myanmar. I think you all know about Myanmar. Myanmar, I think near the between the India and China, and we have a border with Thailand, and then Bangladesh, and currently regarding with the COVID situation in Myanmar, we are not that bad. I don't know why. We don't know why. We would like to know. We have only 262 confirmed cases and only 6 deaths in Myanmar. Next slide, please. Yeah, but almost all the cases are imported cases. Actually, we have only 2 local spread. I mean, without having a history of traveling history. And all the 260 confirmed cases, they are returning from the other country. And you can see in my slide, there's 2 million migrant workers in abroad. Myanmar, we have a 54 million population, 2 million is working in abroad. 70% mainly in Thailand, and then also some working in Malaysia, China, Korea, Singapore, UK, US, UAE, Japan, Qatar, and Macau. And this is our situation in Myanmar. And in Myanmar, we are very much worried because, we have China, and then working in the China border when we have a report about the COVID-19. And then that's why, we have been preparing since January. And but in Myanmar, this is the favorable condition. We have long summer holiday and water festival. In these times, we don't have that much, activities because of the long holiday. But usually we have water festival. This year, we cancel the water festival like Thailand Songkran. We cancel. That's why, the whole April is like a lockdown, but actually in Myanmar, we don't use a lockdown, we use only semi-lockdown. And then because of the summer holiday and hot season, there's not much movement in Myanmar. Maybe that is one of the favorable conditions. And then also not much family gathering because of the government warning, and then also Buddhism. In this period, maybe you know that we have about 85–87% is people are Buddhism. In summer, Buddhism, they are doing meditation, and then we have meditation center. many meditation centers in Myanmar. Next slide, please. And this is our timeline, suspected case testing, we started in the 31st January. Because in Myanmar, we don't have that much testing capacity. Only we have in the central, national health laboratory. And that's why we don't have that much, testing capacity. And we started in January. Before that, we have to confirm with the WHO approved lab that in the Thailand and Singapore. After that, we are allowed to have a test, and then we started in 31st January. And then first 2 positive cases we found in 23rd of March. And since then, in Myanmar, we did massive quarantine. I would like to say massive quarantine, meaning all the returnees are in the facility quarantine. We kept them in the, some are in the quarantine portal, and some are in the quarantine, actually, university, because university, we have a hostel, and then all university are closed, and then these are empty, and then we put all the returnees to the university. And also, I mentioned that meditation center. In Myanmar, in meditation center, this year, no more meditation. But meditation centers are free, and then there's a space. Usually in one monastery, they have about 100 meditation rooms. And then we keep the returnees in the room. And then all the foods and everything we provide. And then they don't need to buy, and they don't need to, worry about that. And that's why, we in Myanmar, we did massive quarantine for 2 weeks. After that, we keep them in a home quarantine. And I mentioned that here in the slide, international flight is suspended on the 30th of March. And then we found the first death in 31st March. And then today, this is the latest, 262 confirmed cases and there's 6 dead. All the 6 dead cases have a COVID comorbidity like diabetes, and then some are the cancer patient, and some are actually came back from the other country like Thailand, and then they have a treatment there, and then came back, and then they have like a cancer treatment. And then positive, we found positive, and then we sent to the dedicated hospital. Next slide, please. And this is, I mentioned that we have 210,000 quarantine. This is massive quarantine. And then we keep in the facility, and government spend the money, and then there's a lot donors, and then, foods and material, and then also university and school took part in this quarantine. Next slide, please. But we still don't know why Myanmar, we don't have that much number of COVID. And then, maybe because of the less number of testing, now we have only, there's 3 places having testing. Every day, about 1,000 tests. Before, we have only 100 or 200 tests a day. That's why maybe that is the reason we have less number. And then also, we don't have that much international flight in Myanmar. Maybe that is one reason. And then also geographically and weather. But now I'm worried about that, because before, Myanmar very hot. Maybe because of the hot season, we don't have that much cases that we thought. But now, in India and Pakistan and Bangladesh, I worry about that, because maybe that will happen to Myanmar the same. And now, in the eastern part of Myanmar, control, Thailand and then Laos and China, they don't have that much cases. But western part of the Myanmar, India and Pakistan and Bangladesh, and then now we are having a lot there. And then now, last 2-3 weeks, most of the confirmed cases, they are back, returning from Bangladesh and, India. And that's why I think we are worried about that. or maybe we already have immunity, hopefully. That's why we don't have that much cases in Myanmar. Next slide, please. We would like to know, actually, the same like other country, when we have a positive case, I mean, the 23rd of March, we stop all the, elective cases except some cancer surgery, and then we finish off all these cases, and then we accept only emergency only. And then we have April, semi-lockdown period. The whole period we are doing only emergency. And then also we prepare for the ICU. And then during this time, actually, I was assigned, University of Medicine was assigned to develop to have a medical COVID-19 medical center. That's why we set up the COVID-19 separate specialist center in one of our university. University was changed to the COVID-19 medical center. And then with a donor from all over the Myanmar, we put the 40-bed ICU, and then also 480 beds. And out of that, 240 oxygen therapy available, single room with air conditioning. And we set up, but because of the not much cases, now we can accept only the negative cases who treated in the dedicated hospital, and then sent to our new center, and then we treated them 2 more weeks in there. And then that's why we don't have that much, but we prepare for the worst. And that's why, and the role of rapid test kit, I just like to know about the rapid test kit and reliability for our future surgical planning. Because, currently we use only CPR, BCR, BCR, but BCR very costly and very expensive. About 120 US dollar for one test. And rapid test is only $3 or $2.5. That's why, like our country, we are not rich country and a poor country, and how we have to apply for the future surgical planning. That is that we would like to know. And also, I don't know, Myanmar, we are very poor, and then according to the WHO standard, Myanmar is very low healthcare standard. How will a healthcare system like Myanmar can stand with the COVID attack? We don't know, and then also we are very much worried about long term and then collapse our healthcare system. Next slide, please. And this is a recent development. And last week, actually, we do have a Zoom meeting with the Ministry of Health and Sports, Department of Medical Services, and University Hospital and Surgery-Related Society. Actually, I was assigned to organize. That's why I organized for the COVID-19 surgical safety meeting. In that, where the output is to form a committee, and then we have to make a national surgical safety guideline. That's why this is a very much entirely, meeting. After that, we are going to make a national, surgical safety guideline. I think you all know Myanmar is very much centralized. And then, we can develop from this, University One can propose to the Ministry of Health and Sports, and then we can apply all over the Myanmar. And after that meeting, actually, we got a 2 billion, actually not large amount of money, 1.4 billion US dollar for the surgical safety guideline development. Next slide, please. Thank you so much. That's all. And, we would like to know, because now we already resumed some of the elective cases since 1st May, 1st June, since 1st June, we all resumed the elective cases, but we can scan, we can screen only history and then, some of the investigation. We cannot do it, PCR, very expensive and very difficult to apply. if we suspicious PUI cases, of course, we did PCR. But for the future planning, we would like to, this is a very much, helpful program for Myanmar. And then we would like to have your suggestion and opinion like, a poor country like Myanmar. Thank you so much. Thank you.
Thank you very much, Professor Zhao, for your presentation. I'm sure there will be some questions, and we can set up a discussion between us as to how we can all learn from each other and how we can take things forward. I would now like to request Joseph Galea to give his view from Malta.
Okay.
Joe.
Thank you very much. First of all, I would like to just, for the benefit of people, because we are a very, very small island, so a bit of geography. We are an archipelago of islands in just south of Sicily, about 60 miles south of Sicily, in the middle of the Mediterranean Sea. Because we are very, very close to Sicily and Italy, obviously we have got divisions of what was happening in Italy at the end of February and early March, where there were increasing deaths and the NHS was not coping. The health services in Italy were not coping with the amount of patients they were getting in hospital. And those films were obviously being beamed on our homes in Malta. And I think that is one of the reasons why people really got scared and worried about it. The population of Malta is 500,000, just under 500,000, about 450,000. And when obviously when the first case came about on the 7th of March, and it was an imported case from Italy, there were a family of 3, and then it went up to 7 cases, 8 cases within a week. And within that week, the government decided to shut the airports and try to contain the disease. By containing the disease, what the plans were to do a lot of testing. And in fact, we are probably one of the mostly tested countries in the world. In fact, our numbers are 25% of the population. So 25% of the population was actually tested for COVID. Because we are a small country, it's actually easier to trace the contacts. So there was a lot of aggressive movement by the public health department to trace all the contacts of all the patients. Unfortunately, we had a couple of wards, and we have got only one big hospital, and a couple of wards, there were actually infection in them. So those were the contacts. All the nurses, the wards were closed, and all the nurses were quarantined for about 2 weeks, and they kept checking them and testing them. We were, I would say, quite lucky as well, like Myanmar, and Australia for that matter, because we only had 649 cases, and we had 9 deaths, and all the 9 deaths were patients who had a lot of comorbid conditions or very elderly. We had a 98-year-old dying, a 96-year-old. The youngest person was a 53-year-old who was on a ventilator because of other problems. He was on prolonged ventilatory support, and he had other problems. He had a kidney transplant, and so he was quite ill. So that he was the youngest person that died. Obviously, the positives were from all ranges. Now, what did we do from the surgical department, because that's the point of the meeting today. The first thing we did, by the way, we didn't have a full lockdown like some countries did. The construction business continued. The people who could work from home were obviously sent home, like services. But the manufacturing, which is not very big in Malta, that continued going. What obviously stopped was restaurants, bars, and all the tourism, which basically paralyze the country, because it's a country that depends mainly on tourism. So we had a few cases in the beginning, and then as I told you, we stopped all non-emergent treatment except for cancer surgery, like they did in Australia, and I think in Myanmar as well. We continued doing cancer surgery. I am a cardiothoracic surgeon. We stopped doing elective surgery. I did a couple of emergency CABGs, and they were scanned, and all patients were scanned and tested for COVID. Another thing that the hospital did was to separate the emergency department. So what we did was we had one emergency department, and we actually opened a second emergency department on the opposite side of the hospital. So the patients will go to the hospital. They all treat it as potentially being positive, and then and they sent to an area where there were possible COVID plus patients, COVID positive patients. The ones who were negative were put on wards. The ones who were positive were either sent home if they were fit to go home, or kept separately in the hospital. If they needed surgery, they will get COVID, and we still do that till now. So all patients get COVID tested within 48 hours of the operation before we go for surgery. Now, what happened, because we have one hospital, we only had 25 ventilators. So what was the plan by the CEO of the hospital and the medical director and the Minister of Health was to try to buy as many ventilators as possible, so that if we get the big wave of cases in intensive care, we could cope with that. And that's one reason why we had a section of the operating theater all turned into intensive care beds. Thankfully, they never had to be used. So I think what we're going to discuss today is what is the plan now. Well, what the plan now is, what happened now is that from the 1st of May, from mid-May, we started increasing the elective cases. I mean, from a point of view of cardiothoracic surgeon, I can say that I had patients that were, waiting with, even left mainstem disease, with, valves that were quite so we started doing those cases. We are 3 consultant surgeons, and we're given 1 day a week each. The same happened in other specialties. So up till now, at the moment, we are at 60% efficiency. So we are not yet up to 100%. We are planning to be in 100% by the end of July. So at the moment we are doing 60%. We are slowly increasing. Another big problem was the fact of laparoscopic surgery, because laparoscopic surgery was one of the things that, they were the dispersal within the air of the theater. So they created new things like, new filters and stuff like that, which we are going to keep now. There were some changes that we did in the hospital. Like, for example, we had 1 CPOT theater, and now we have 2 CPOT theater, and we have an extra emergency theater. So they can, we are now can deal with more emergency patients than even before the COVID pandemic came around. And I think these are changes that some of them we are going to keep, because I think they work well and they are more efficient. So we have improved our efficiency what we can do in 1 theater, although we reduced the number of theaters. We had and still have a COVID theater, and those COVID theater is manned by the nurses of one of the CPOT theaters. So if there is a COVID case, a group of nurses from the CPOT theater will go into that, and obviously will all be protected and do the surgery in that part. Another thing that stopped for 2 months was the endoscopy lists. Our endoscopy lists stopped, even the diagnostic ones, again, because of the worry of aerosol, and now they have started from the 1st of June, and while they are being operated, PPEs are used all the way to do that. So we are slowly easing out from the system, and the patients are, started to be treated again and going back to normality. This normality is also done by the government. Actually, in a couple of weeks, in the beginning of July, the airport is going to open for a few countries, and by the 15th of July, it's going to open to all countries. So this is what the situation in Malta is now.
Thank you very much, Joe. From the three presenters, what I can gather is that we all seem to have a very similar way of getting back to normal. If I can say this, you are the fortunate three among us, because we have been affected quite badly. And you obviously have a plan to go back to normal. You've got time frames to go back to normal, which I must say is something that we will probably have to wait for a much longer time to get back to that same situation. I have a question here for Professor Zaw. The question is it necessary to take preoperative nasal swabs for surgical patients?
In Myanmar?
Yes.
Not really. Actually, if the case is PUI, if suspected, traveling history, and then also, positive, that they come from a positive area, and then fever, and then, symptom, we put as a PUI, and then all the PUI cases have to take the swab.
Okay.
But for future, that is impossible, because we can test only 1,500 tests a day for the whole country. That is impossible to apply that to our situation. But we need to resume our regular, elective cases. And then, there might be some cases. And then also, if it is PUI and is okay, we can manage with the swab. But, that's why we're thinking the quick rapid tests.
Right. I hope the person who asked this question is satisfied with the answer. And what is being planned to deal with long waiting lists of surgery patients, particularly in low-income countries? Again, to you, sir, Professor Zaw. The long waiting list.
Actually, I'm orthopedic surgeon. And then also we have, there's joint replacement and spine surgery. But orthopedic is actually, they can wait. But this is not our emergency. But I will hand that over to the Professor Tintin Ma. She's a liver surgeon, and then she has a lot of cases, and she will answer. Yeah.
Hello. For that question, for the cancer surgery, so we do the meeting, multidisciplinary meeting, who will get the benefit for the cancer surgery. We select the cases because we have to consider about the ICU bed and then the good recovery. So we will select the cases. And then there is some cases we start with the adjuvant therapy, neoadjuvant therapy, and then the surgery. So for the cancer surgery, we decide that. And for the benign cases, because as for the hepatobiliary, we have a lot of stone cases, and gallstone and intrahepatic stone. So for that part, we consider about that is just delay the operation, but sometimes it's with the cholangitis. On that time, we have to go. So on that time, we start with the standing or BT-SPD or something like that, and then we will go for the surgery. So for the elective cases, we select the cases who will get the benefit from the surgery.
Okay.
And we decided. Okay, you got it, yeah?
Right. Tintin, if I can just ask you, with these long waiters, do you restage them again? Because some of them can get upstaged during the period that they've been waiting for the operative procedures. So do you redo all of the investigations before you start them on neoadjuvant treatment?
Yeah. So for my department, so when we start the operation at last week of April. So on that time, my waiting list is around about 45 or 50 cases. So we connect the patients, and then we see the harms going on. We prioritize. We like the triage, who will get the benefit from the surgery. And then some cases we offer the other alternatives treatment, maybe the adjuvant therapy and then the access. Sometimes we have to consider about the age, elderly, and then there are a lot of comorbidity, and then there's a strong suspicion of something on that time. We will consider the other treatment instead of the surgery. For the surgery, it might be the resectable. Resectable cases, we select the cases. And then they definitely got the beneficial from the surgery. And then the recovery period would be not long. So we have the selected cases with the meeting. And then they put up the cases and arrange the cases according to like that. And then we start. Yeah.
Okay. Thank you very much, Tintin. The next question is for Jonathan. Jonathan, can you elaborate more on the public and private relations which you have mentioned in your talk?
Yes, thanks for that. So I guess in Australia, there's a dual system, a public system or an NHS style system. We call it Medicare. It's equivalent to NHS in Britain. It's a public system funded by the government via taxpayers, and then there's a private system, and it varies, but let's say it's about 50-50%. Patients would go through one or the other system. What we found was when the sort of lockdown happened and the surge seemed to be happening and elective surgery was cancelled, the private hospitals, there was a lot of very elective surgery, plastic surgery, a lot of orthopedics, ophthalmology, and so on. So that the private hospitals had a dramatic reduction in their throughput. On the other hand, like Myanmar, we still had a number of cancers and other urgent sort of patients to be done, which, because the Alfred was sort of put in charge of a geographic cluster, couldn't really do many elective cancer cases because there was a risk of blocking ICU beds. So these had to be transferred out, and as a result, the respective governments brokered deals between public hospital providers and private hospital providers to treat public or NHS patients in private hospitals. And look, it worked extremely well. In our own unit at the Alfred Hospital, which we deal with a lot of breast cancer and quite a bit of endocrine cancer, I guess. Most of that was actually done at surrounding private hospitals, so that the Alfred itself didn't become blocked. But as I mentioned in my presentation, it ended up with a very unusual and almost eerie situation of a major public hospital being slightly empty with little activity happening. So it was a very odd, bizarre feeling. But look, that system's worked well. It's about to stop because we're meant to be back to close to 100% like Malta by the end of July of our elective surgery. In terms of the long waits, we don't have any particular plan, but you know, I think everybody's keen to work hard and get through it. But there is a huge backlog. I think the other thing is that I was interested to hear about, you certainly do need to sort of reconsider where your cancer patients are at, but I think we've been continually reviewing a lot of our patients, reclassifying, re-triaging, seeing, who's deteriorated for whatever reason and acting on that. So I think that's been another positive outcome of this in a way. Thank you.
Thank you very much. Joe, this is for you. We cannot trust questionnaire screening. At least cases for admission for surgery or endoscopy should be tested. I suspect you guys are still testing everybody who comes into surgery, even though you've got a COVID-rich and a COVID, less arenas in your single hospital in Valletta.
Yeah, we are screening everyone who goes through the doors of the hospital. So everyone who goes through the doors of the hospital, whether they have fever or not, they get a test. If as the surgery is very, very, very urgent, like trauma cases, we go to casualty and see the patients all in PPE gear because you don't know what they are. And if they can wait for the test to come out, then we can operate the next day, even sort of, to get these, what I call not emergency cases, but urgent cases. The urgent cases, well, all cases are tested. In Malta, all cases are tested. Apart from that, those people who are quarantined are tested, even though, for example, if they are contacts, they get tested. Then everyone who has got symptoms is urged to go and have a test. And for a small island like ours, we have approximately 1,500 tests a day. So yes, I think our system, and because we are small, obviously as well, so we can, I think the whole thing that was used in Malta by the public health department and everybody was test, 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 and test again. And I think that's possibly why we had such a small number of cases. Because even though if you test, you are going to pick up more.
Indeed.
Our mortality, if you look at it, was around 1%. 9 cases out of 659 cases. So yes, and we still do that, Raj. We are still testing patients every day. If I do a bypass tomorrow, these patients would have had a test yesterday and the result will come out today and he'll have the operation tomorrow.
Jonathan, a question for you. With the benefit of hindsight, what would you change in Australia's response, if any? Interesting question, that.
Thank you. Look, I think Australia has managed to do extraordinarily well throughout this. Victoria, where we are, still is having little outbreaks. There were 12 new cases yesterday, and we have had very few days where there have been 0 new cases. But other states, the smaller states such as Western Australia, South Australia, Queensland, for example, and Tasmania have had a number of days with no new cases. So look, the virus is still out there. I think one of the keys to the success was the very early border closures and also quarantining all overseas arrivals for 2 weeks were sort of placed in quarantine within hotels. And that really happened from mid-March when we thought we were on a massive case surge. So that was a very important step. We've done a number of similar things to what's been mentioned in Malta and Myanmar. The other thing we've done is use the COVID Safe app, which is an app you have on your iPhone. It's in Singapore as well. And if somebody gets COVID, it identifies you as a close contact, so you can be immediately contacted and screened. So I think the contact tracing has been very, very helpful. But look, I can't really say what we would have done differently otherwise. I think the laparoscopy question is still open to debate as to whether it is or isn't an increased risk. I think it's different to the sort of aerosol generating procedures such as ENT. We also had major plans for surgeons to become redeployed as ED consultants and ICU consultants. We had huge numbers of plans, which, gratifyingly, unfortunately, we never needed to put into place. So I think I might leave it there, Raj. Thank you.
Thank you very much, Jonathan. Professor Galia and Professor Zaw, small countries like yours and mine can acquire ventilators and equipment, but how should we address manpower issues? Ventilators need highly trained teams. So, Joe, can you address that first, please?
So, that was something that was really, really worrying in the beginning of the pandemic, because we were actually told that everyone, surgeons, surgeons, other doctors, GPs, need to learn how to manage a ventilator, because we never know how much we were worried. I mean, graphs were drawn and, we're saying, that we were going to have 200 cases on a ventilator and stuff like that. And obviously there weren't enough people to man those. So we had a week of tutorials of how to use ventilators as surgeons, including orthopedic surgeons, including everyone. So this is how we tried to, thank God we didn't need to do that, but actually because manpower is obviously extremely important. And so we got trained to do that in the beginning of the pandemic. So if that answers your question.
Okay. Now I'd like to hear from Professor Zaw how they managed it, albeit a small proportion of patients that they've had there. But how did you manage it, Professor Zaw, in Myanmar?
Yeah, actually, this is a question that we have been asking, when we have a first case just in the, March. And then at that time, all over the world. And then also, I think Myanmar, the WHO, and then also Raya College calculated Myanmar having a 4,200 dead. And then also, a lot of cases. That is estimation. That's why we're having a lot of problem. In Myanmar, actually, we have only 300 ventilator for whole country. And you can imagine what will happen, And then, but we have 400 anesthesiologists in Myanmar. Actually, also, this is a worrying problem. Because, 400, how can manage with the 1,000 of cases? But we are lucky. We don't have that much problem. And then that's why, government assigned me to prepare the COVID dedicated center. And then I have, in Yangon, we have 3 centers. Each and every center have about 20 ICU beds and ventilator. And then also, I make it a new center with the ventilator. Actually, at that time, because of the lockdown and because of the border closed, and very difficult to get a new ventilator, very difficult. Even though we have funding, we cannot buy the ventilator, That is also a problem. At that time, some of the people, they try to make a ventilator, local make ventilators and things. That's happened to Myanmar. But last month in Myanmar, we got World Bank, money, 50 million, US dollar to set up the ICU and ventilator in Myanmar. And then government asked me to propose for that proposal. And then that's why now we are having a 2-year plan to fulfill a ventilator and then training program. And then first 6 months, we will start with the remote area, and then, some of the districts, they don't have ventilator. And then we will put the ventilator there because we still worry about the COVID-19. We don't know when we are having the immunization and then when we are, having control. That's why we need to prepare for that. And that's why we have, we did the proposal, and then government and World Bank, we got money now. And then we can plan in the 2 years time to cover the ICU and then ventilator for Myanmar. And then we are going to start with, actually we do have we did short courses with the anesthetists, with the help of anesthesiologists, to the master degree, student, and then master degree holder for the, different specialty. We train them how to use the, ventilator. Actually, luckily, they never had a chance to use the ventilator. And that's what we did. And then also now we are planning, actually I have agreement with the Royal College of Anesthesiology, UK, and then also Cambridge. Actually, I have been trying to develop ICU in Myanmar for the last 3-4 years. And then we are having some program with the help of the Royal College in Cambridge for the development of ICU in Myanmar. And then we are, our plan, after 2 years, we will have a master degree program for intensive care. That is our, experience and situation. Thank you.
Thank you very much. Thank you very much indeed. I have a question from Anusha Balasubramaniam. Are there any plans or strategies to rapidly operate on the non-urgent, non-cancer patients who have been cancelled? Example, operating on Saturdays, Sundays to reduce the backlog. Can I address this to the panel? Jonathan, Saturday, Sunday operating to reduce waiting lists of non-COVID chronic waiters?
Look, it's an interesting question. I guess it all comes back to the economics of it, how the hospital's funded, how the hospital earns its WEES and that sort of thing. Certainly in Melbourne, we do Saturday operating lists for public patients from time to time to try and reduce waiting lists, and I'm sure that'll happen again. It hasn't formally been on the agenda at the moment. And we still seem to have this issue in Melbourne, particularly about PPE and face masks. So going back to the previous question, what could have Australia done differently? I think sort of having a better preparedness and supply within the country of its own PPE would be one answer to that question, particularly face masks.
But that has been a universal problem. Preparedness, even in the UK, I think we came short on our stocks for PPE. This is still being debated. We have some hospitals and trusts where they seem to be well stocked, while others are still struggling. Joe, Saturday, Sunday operating, you're used to this as a cardiac surgeon, aren't you?
Yeah, we are in a way, but the government, I mean, from the point of view of all surgery now, I'm going to talk rather than just for cardiac surgery. It has been, in the past few years, the government used to give us what's called incentive lists. Incentive lists means that you do operating outside your time and you get remunerated for it. So there is no reason why this shouldn't happen again, because it's something that has been done. If, for example, we realize that knee replacements are falling back by about 9 months or a year, in that case, an initiative list is given for orthopedic surgeons to increase the output. And that would be operating on a Sunday or operating on a Saturday. But we work on Saturday. Saturday for us is a working day. So, so you can say it's a morning only. So you can actually add cases, for example, in the afternoon on Saturday. But those are usually, people have to be paid extra to do that. It has been done before. It has even been done in private hospitals. For example, if it's minor surgery like, hernia, even, not so minor like hip replacement, knee replacements, they can be done in a private. I can't see why not. There are no plans just now. We are just recovering from this. So no plans have been done yet, but I don't see why not, because it has been done before for lesser evils.
Right. Professor Zhou, any thoughts on that? I saw.
Yeah, actually we will answer, because I answered some of the part of your question, and then Professor Momo from University too will answer the. Actually, Saturday, Sunday for us, we operate in the private clinic, private hospital. Because in Myanmar we are very low salary, and then we have to keep the time for us, and then we have to operate in the private hospital in Saturday, Sunday. Maybe a bit difficult for us. Maybe Momo can answer some of the questions. Idea. Yeah.
Yes, I totally agree with Prof. Song, because Saturday and Sunday is we work at the private hospital. It's for us, like he said. And the other thing is, in my university, we have our anesthetists. They have to go to cover the ICU for the COVID patients. So we are a bit short of the anesthetics as well. So if, as a general surgeon, even if I wanted to operate on, let's say, Saturday, leave along Sunday, my anesthetic, they might be very angry, because they are very short and they have to go around the ICU and look after the COVID patient as well. That's one thing. And my idea, we do need maybe rest, maybe Sunday. At least Sunday should be the rest day for all the doctors working in the hospital. And we also have emergency surgery. They are either cancer patient or trauma patient, and there are lots of trauma coming as well. So I do think we also have to look after these as well. So Saturday is possible, but that means that we have to give our the day that we earn our salary or our government patients. But if everybody agree, it's okay with us.
Very interesting indeed. In my unit in Birmingham, we actually used to do a 6-day operating, as Joseph would remember. And then we also did Sundays to catch up on some of the chronic waiting patients. However, now what we need to realize is that it's the same nursing staff, the same theater personnel who have been working relentlessly over the COVID period, who will have to double up again. So it's not going to be very easy with the same workforce that we have. In Birmingham now, having listened to all the presenters, we have a non-COVID designated hospital. We have a private hospital which has also been designated as non-COVID. And we have one hotspot hospital called the Heartlands, which is now being reconfigured for COVID patients, and the University Hospital in Edgbaston. So there have been reconfiguration of services going on at the present time. But we have been hit a lot more than all of the 3 countries that I have been speaking to today. I'm going to see if we have any other burning questions, because we have just gone past the hour. The final question is from Joseph Elul. How do the panel feel that this crisis will help us to improve our systems efficiency in the future? Jonathan?
I guess I'd touched on this a little bit, but I think there are a lot of positives out of this. I think being able to review waiting lists, triage patients, the value of meetings such as this, efficiencies within operating rooms, outpatients. I think all of these things have come to the fore. I think telehealth is something that we have grabbed with open arms and have recognised the value of it. It's not possible to do it for all patients and all conditions, but it's certainly possible to do it for a lot of patients. And you know, from a patient's perspective, it sort of means they're out of action for 20 minutes or half an hour rather than giving up a whole day to come to a 5-minute appointment. So I think there have been a very large number of positive outcomes, and certainly I feel the way we're going to be practicing surgery and medicine in the future is permanently changed in light of this pandemic.
Thank you. Thank you very much, Jonathan. Joseph?
I agree completely with Jonathan. I think, you know, what we have seen, especially with telemedicine now, what we didn't know that will work. I mean, I was lecturing because our university has closed. I was lecturing, you know, from my office, from my home. We can interact. We had outpatients done on the phone, and then select patients to come in with the ones that so I think we can make our outpatients a bit more efficient. And I think another thing, which is maybe a bit cheeky to say this, but I think it could have put a brake on some bad habits in the operating theater of delays and stuff like that, because now we have to be more efficient. And it's a good time to change, because then, you know, if you are going to start afresh, then you can maybe allocate theater time better to people, which you have been trying to do for years, but you couldn't. And I think that has opened an opportunity. And I that mentioned as well in the beginning, for example, we have realized that having 2 CPOT theaters instead of 1 is probably something that's going to stay. Another thing which was really interesting is, for example, they had an obs and gynae theater which was separate from all the theater suite. And now in this COVID, they are doing all the emergency Caesars up there and the elective Caesars in the main theater, which they didn't use to do in the past. They have become more efficient because now the theater up in obs and gynae is being used, and it wasn't being used because everyone wants to do them in the main theater. So, you know, this obviously is going to cause increased efficiency, and I hope it does anyway.
Thank you, Joe. Professor Zaw and his team?
Yeah, actually, I feel this. We feel the same, and there will be a lot of changes in future. I think because of the pandemic impact, and then I was thinking even, you know, some ethical and then, you know, social and communication, and these are the things that will change in future. I think maybe in future probably we might have one module or one program like that. You know, there will be changes in training programs and things. I mean, from Myanmar side, because of we have less number, and then this is an opportunity for us because government invests a lot of money in the health now, and then now we are having ICU and then ventilator, and also now the government put some money in the surgical safety. That's why we feel like that this is a very good opportunity for Myanmar. I mean, healthcare in Myanmar. Thank you.
Thank you. So, gentlemen, we've passed our time. I'd like to thank Professor Jonathan Serpel, Professor Joseph Galia, Professor Zaw, Professor Tintin Ma, and his team for an extremely exhilarating and for sharing all their views. And I'd like to thank you once again for taking the time to participate in this very interesting webinar. Thank you very much.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you, Jonathan. We will keep in touch.
Thank you, Raj.